All right, welcome to Table Talk about CP. I'm Will Benson, one of the physical therapists here at Anna Shaw Children's Institute.
And I'm Becki McBride, one of the occupational therapists. And did you know that March is Cerebral Palsy
You're
Awareness?
right, it is.
Yeah. So we're going to talk a little bit about CP.
Yeah. So this is kind of what we're going to talk about today, what it is, what does therapy look like, and then maybe what are some pieces of equipment that kiddos with CP might use.
Absolutely. So the definition of first of all, we're saying CP, but it's really
Cerebral palsy.
or cerebral. I sometimes say cerebral palsy.
Same.
I don't
Most
know
of
which
the
one's what.
most of the
Right.
time I just say CP.
So cerebral palsy is brain damage that occurs either before, during, or after birth. There's a few different things that we've listed here that can cause it.
Right, like a lack of oxygen to the brain or a brain bleed that might look similar to a stroke. And then even trauma in infancy. I think it's like up to 18 months of age. If they have any kind
Okay.
of trauma, that can be classified as CP, versus later in life, it might be classified more as like a traumatic brain injury.
Makes sense. There's different types of CP. I've seen children that have it affected like one side of their body.
Right.
So like their arm, like maybe their left arm and leg, and that's called
Hemiplegia.
right. And so then if it affects maybe just the arms or just legs, that's a different name.
Right, that's diplegia. But in my experience, most of the kiddos that I've seen with diplegic CP it's mostly the legs. I don't normally see kiddos with CP who just their arms are affected.
Do you ever have anybody that has it affected like everywhere?
Yeah, I mean, we would call that quadriplegia, and they might have a harder time, even holding their head up, sitting up with like better posture, and then their arms and legs are affected as well.
Yeah, that's what I see.
All right, so there are some different classifications of CP based more on their movement patterns.
Okay.
So we have spastic CP, which is the most common, wouldn't you say?
Absolutely. But spastic, that's a word. What does that exactly
So
mean?
it's going to be like when those muscles are tight and they have a really hard time moving through their full range of motion.
Okay.
Then we have dyskinetic CP, which is characterized by uncontrolled jerky movements. So this might look like, and this has happened to me a lot, when I'm working with a kid, I might be stretching them or we might be working on sitting, and they have this dyskinetic movement where they kind of hit me in the face.
Right.
And not because they're trying to, but
Right.
just because they can't control that movement.
I've seen that also. Ataxic is another one.
Right.
And that really impacts the balance, gait, depth perception. I haven't seen that as much, but what I have seen is like a mixture. So I've seen,
Yeah, so
what is that?
when we have multiple of these movement patterns that kiddos with CP have. So like they might be spastic, but then they might also have difficulty with balance and gait. And so they have both spastic CP and ataxic CP.
And one of the things that I see when I'm working with kids is maybe they have trouble sitting up.
Right.
And so maybe they don't have as much control in their trunk.
Right, yeah. So they have like low muscle tone or hypotonia.
Yeah, yeah.
So in school, one of the analogies that I was taught that I really like to use when I'm teaching parents about tone, which I talk to a lot of my parents about tone, not just with kiddos with CP. But think about muscle tone as like this rubber band, okay? So when it's really loose, that's what we would call low tone.
All right.
And then we have what we would consider like normal muscle tone, where you put like a little bit of stretch in it. And that's where muscles really work the best. Now, if you have hypertonia and you put a lot of stretch up into the point of where it's like about to break and it's really tight, that's, also going to make movement a lot harder for those individuals. And then we also have that fluctuating tone between like really loose and really tight. And that's what we would call like athetoid type movements.
I gotcha. So if I'm watching this at home and I think, oh, I'm worried about my child,
Right.
like what would be some things that I would need to look at?
Yeah, so we definitely would expect kiddos with CP to have some like slower milestone, meeting those milestones a little bit later than what we would consider typical. Also, when you're changing them, their diaper, their clothes, or when you pick them up and you notice, they're really tight, they don't want to like move from certain positions. So they're really floppy, and when you pick them up, they just kind of,
Right.
flop and hang there. So any of those abnormal tones that we've already talked about. And then abnormal postures, so like keeping their arms and legs like really, really straight or really, really tucked up, or you notice they're stuck looking one direction,
Right. And with that, maybe when we're talking about those developmental milestones, so maybe they're not able to reach and grab toys like we would
Right.
see like
Exactly.
babies, that kind of thing. Yeah. There's some related conditions that we have listed on our slide too. Well, there's several different ones. One of the ones that I see a little bit more of is the impaired vision.
Yeah.
Contractures, that's just means when Will was talking about the really tight, when he had the rubber band and pulling it really tight, that's just looking at those muscles kind of being stuck. Maybe I see it with kids that have a fisted, their hand stays fisted. Another one is the scoliosis, and some deformities with that. Again, if you think about not having as much control of your trunk, that would impact how your spine
Right, or
looks.
even that muscle tone, if you're have that tighter muscle tone
Oh
on
yeah,
one
that's
side
true.
and all your muscles are connected to the spine and
Then
they're
it's gonna
pulling and
pull.
rotating.
Absolutely. Sometimes we'll see an intellectual disability. Again, you won't see necessarily all of these
No.
with CP, but we just
Right.
wanted to mention a few. And
Yeah.
there's one more we left off.
Right. I do feel like a lot of our kiddos with CP do have, seizure-like activity as
Yeah,
well.
we do see that. Yeah, definitely.
All right, so you know what? Let's start talking about what do therapists work on with kiddos with CP?
Yeah.
So in physical therapy, if they have those contractures or those tight muscles, we're going to work on stretching them out. And I do look at the whole body, but I mean, kind of generally thinking, a lot of times my focus is on the legs, those hamstrings, the muscles on the back of your thigh that are in charge of like bending your knee. A lot of kids get stuck in that bent knee position.
Right.
And if we're going to be working on walking, then we got to get that knee straight. And even if we're not going to be working on walking, we want to prevent any kind of pain from setting in.
Now, I'm going to interrupt you here.
Yeah.
When you mentioned that about walking, I would think that's what a lot of people want to work on.
You're right. So I feel like that's a pretty good assessment of what a lot of parents want to work on when they come in for PT, regardless of the diagnosis, is I want my kid to walk or walk better. Now, I will say that that's not always my goal. Sometimes I'm looking at getting mobility equipment that either will help them walk better, like a walker or something like that. But sometimes kiddos with CP, their tone is too strong, or they're too floppy, or they're just so weak that we might use something more like a wheelchair. And my goal as a physical therapist is to really promote independence with mobility, whether that is walking or using some kind of device.
Yeah. And in the picture here, what is that?
Okay, yeah. So that's a light gate. It's a really cool machine. We have one here at Anna Shaw. You can hook them up into this little harness so that they don't have to support their full body weight. You can kind of control how much of their weight that they're accepting, and then they can walk it around the hall, or a lot of times to work on a lot of repetition, I put them on a treadmill while they're in this so they can get a lot of practice in taking steps.
But that's a lot of fun.
It is. So Becki, you're the OT, you're the expert in the room on this. So tell us, what does OT work on with kiddos with CP?
Well, like you said, that even though you don't only just work with legs, I don't only just work on arms, but I kind of do.
Right.
So in this picture here, we're working on, we're sitting on a swing, and so what we're really doing is trying to get our arms kind of stretched out, trying to hold on with both of them. Sometimes I see kids that maybe use one arm a lot more than the other. And so that's one of the things we want to work on. We want to use our arms. We want to use our eyes and hands working together. And just the functional part of that is being able to put on a jacket or put their, maybe go into the bathroom or being able to feed themselves, those type of things. Another thing that we'll look on is, one that we address with OT is the sensory.
Right.
And so, for example, sometimes, not always, but sometimes when I work with kids with CP, they have a hard time focusing. So sometimes they have a hard time with just if there's a lot of things going on in the room. being distracted. And
Right.
so sometimes we'll have to work on that, figure out
Yes.
ways to kind of address that, whether that's in the community or at home or at school. The other thing we do is if you think about some of these kids haven't really moved in the same patterns that
Right.
we have. And so giving them those kind of opportunities
Mhm.
is really helpful for that developmental progression.
Right. I'm glad you threw in that statement about like you don't always see this one thing or you don't always work on this one thing because what's one of our favorite sayings?
Oh. If you've seen one kid with CP,
You've seen one kid with CP because no kid is going to present the exact same way.
absolutely. Now, neither of us are speech therapists, but we can kind of try to address this just a little bit.
We do have a great speech team
We
here at Anna.
absolutely do. We actually have someone that's a feeding therapist.
Right.
That's her specialty. She's in the speech department. And so if you think about when we're talking about some of those muscular issues and tone, what would be difficult would be swallowing. And also what would be difficult is being able to move things around in your mouth.
Yeah.
And so we have someone here that works on those kinds of issues that we see.
Right.
We also have work on issues with speaking. So just being able to verbalize.
Yeah, because if you think about it, if you know you're not properly positioned
Mhm.
and that muscle that's in control of your breath, that diaphragm, if it's
Right.
spastic or if you're kind of in a difficult position for it to move, you're
Mhm.
not going to be able to make words and speech like someone without CP.
Right, right. Now, a minute ago, we talked about how most people want their kids to walk.
Yeah.
And so I would say when we think about speech therapy, what do parents mostly say?
I feel like a lot of times they say, I want my kid to talk.
Right. But we know that that sometimes isn't an option for some of our kids just because of just the motor impairments
Right.
and just a lot of things going on. So in the picture here on the slide, you can see it looks like an iPad and there's some pictures on there. There's different ways that we use these assistive technology or augmentative communication devices to be able to communicate. And so we have ones that you can use their finger and you can maybe hit a ball and it says, I want a ball. But what is really neat is we have some that you can use your eyes.
That's
access.
Amazing.
If you think about that, think about not having really great control of your arms and or your legs or being able to sit up. And you have a lot of things to say. And so being able to use your eyes to be able to communicate, that's just is so exciting to me. We have, I don't know, probably about 2 or 3, that we're working on that with. It's just really fantastic.
And that's kind of a cool overlap, that OT and
Exactly.
speech share, right?
Absolutely. Yeah, it's a lot of fun.
All right, so, let's talk about some of that equipment that we've already kind of mentioned.
Right. Some of we mentioned feeding with speech and OT, we kind of look at that as well. And so in the picture, you can see we've got some seat that provides a little bit more support.
Okay.
This one I like because it is adjustable and you can actually sit at the same height that everybody else does. And it provides sometimes just enough support for that feeding. I usually look at being able to feed themselves if possible. And so with that, sometimes we need some extra help, like maybe a spoon that's curved or maybe a plate that has a ridge on the side, and that just kind of helps with the scooping. We also have a picture here of a cup that's kind of cut out at the top. And that just makes it more safe for some kids to be able to drink without kind of tilting their head back. And then that way just provides more independence and more safety with feeding.
So orthotics are something that we both do a lot with. So a lot of times as a PT, I'm going to work on those orthotics that, are on the legs. So depending on the severity of the motor impairment, we might have things that we call SMOs, which are like the short boot style ones that you can see in this picture. They just come up above the ankle.
Okay.
Other kids might need a little bit more support. And so we're going to have braces that either come up to the knee or sometimes that come up a little bit further onto their thigh or even onto their hip.
And then there's a picture of, I call it a hand splint. And so a lot of times we'll see, I think I mentioned earlier, a lot of kids maybe have their thumbs in their hand. and it's really tight. And so we'll work on kind of stretching and get that out. And so the splint does that for them. We use ones that are soft or some that are a little more hard. And so again, you're just trying to do that so that, and then also just to prevent fractures or tightness,
Yeah.
that kind of thing.
All right, and so you probably have a little bit more experience with the more assistive technology side of things, and we've already talked about the AAC device.
Right, and the other picture here, again, going back to some of our kids that have difficulty with movement patterns. And so they really, if you think about being able to play with toys, what that looks like. And so we have here at Anna Shaw several different, not these in particular, but we do have several different switch activated toys.
Yeah.
So I have a kiddo that all they do is just kind of press a button and then it makes something happen. And so
Right.
they're getting to enjoy play
Yeah.
and toys in a way like their peers.
Right, and I feel like that's such an important aspect of
Mhm.
like we don't just work on those big things like walking or self-care.
Right.
Because so my wife, you know her, she's an
Yes,
OT.
Annabelle.
She talks about occupations are things that you want to do, have to do, or like to do. And so
Absolutely.
all right, so let's talk about some mobility equipment. I think I've mentioned most of these before, but you know, some kiddos might need a little bit more support with walking, and so we might use something like this, like a gait trainer or a posterior walker. So they just have a little bit more support. They can use their arms. A lot of times, my kiddos with diplegia use something.
Okay.
Now, other times, kiddos maybe walking's not their main form of mobility, but we want them to be independent. And so we might get them more like a manual chair, like you see this little cutie in at the top. And then other kiddos, you know, they might have a hard time, you know, pushing the wheels themselves. And so we're going to look at something more like what's down here on the bottom, well, like a power chair that they have a little joystick that they can use. And guess what? They don't just use joysticks. Depending on the severity, they have like what we call sip and puff. So they have a little straw in their mouth.
That's neat.
They can suck in or blow out to make it move directions. They even have ones that you can use your head movements to make your wheelchair move.
Because it's really all about
Independence.
independence. Exactly. Yeah.
So if you want to take a look at some of our references that we got our information from, here are some. There's not a ton because, you know, we work with kids every day with CP. So if you have any questions about CP, our emails are right here. You can definitely reach out to us and we can help answer any questions. But also, if you're concerned about your child, what's the best thing that a parent can do?
Absolutely. You can talk to your pediatrician and also just ask about those developmental milestones or check in with Amy Shaw.
Yeah.
Yeah. All right.
Thank you.
Thank you so much.